We'll get started. We can cover our agenda and get you out here on time. Just a reminder to all members, even though you may have been here this morning and completed this member reimbursement form, you need to complete it again. Just make a note that you were here this morning and completed the sheet as well. So turn those in. We'll get those processed. I'm Donnie Lambeth, and I'm serving as chair of this group this afternoon. And we're going to focus primarily on Medicaid. We had a lot of good discussion this morning. But we do appreciate each one of you being here and taking time out of your busy schedules. And with that, we're going to start with Secretary Kinsley, remarks from the department, and you're going to focus on Medicaid this afternoon more than any other topic.
Yes, sir. Thank you, and good afternoon, members of the committee. So as I mentioned this morning, but to mention again, our Medicaid expansion enrollees are currently at 389,411. We're adding approximately 1,000 individuals per day, about twice as fast as the other states that have most recently expanded Medicaid. Our campaigns are going strong with over 30 million impressions on social and 133,000 website clicks. We've translated our materials into Spanish, Russian, Arabic, Chinese, and Vietnamese for language access. We'll be sure you get copies of those, Chairman. Wanted to also share, folks are probably aware that shortly after our last oversight hearing, we released the request for proposal for the Child and Family Specialty Plan. This RFP is out for proposals due May 1st. As you can respect, the department is in a silent period with regard to this proposal, and so we will be going through that process. We appreciate the General Assembly's support of pushing this forward to create one statewide concerted plan to help support children that are in the child welfare system and their families to get more coordinated care. About a week ago, the department put out a federal proposal on how to cover new sickle cell therapeutics. Many of you may be aware that there's a new curative therapeutics for sickle cell, which is a disease that approximately 6,800 North Carolinians live with. It is incredibly painful. The therapies are incredibly expensive, and so we're working with the federal government to increase access to these therapeutics and to make them more affordable for the state so that we can help support them, and using this as part of our strategy to try to bring down cost also. And last but not least, before I turn things over to the team, I wanted to mention that as this committee knows, we have been working hard to combat the rising syphilis epidemic in North Carolina that is really consistent with what we're seeing across the country, particularly concerning for congenital syphilis. In the last 10 years, we've seen a 72-fold increase in congenital syphilis infections. And so our Medicaid program has been central to this work by increasing more coverage for screenings, by ensuring providers are reimbursed for treatments in office as opposed to having to refer out of office, and other strategies to make sure we can ensure that these babies are born without syphilis. I'll now have the great pleasure of taking questions, and in a moment we'll turn things over to Deputy Secretary Jay Ludlam, who leads our Medicaid program, and his team to give an update on eligibility, to talk about tailored plan readiness, and to follow up on some issues that I know we covered together last time we were here around tailored care management, our EVV system, as we continue to make sure our Medicaid program. I just want to brag on them. I'm so grateful for their work. What most other states, I think, do in about a year's time, they do at 7 times the pace, and we're really, really proud of them. So, Mr. Chair, thank you for the time.
Do you think they could pick up that pace maybe to 8 times?
Well, you always, with your support, yes.
Okay, questions from committee members? Representative Blackwell.
Surprised. I decided I needed to beat Senator Bergen to the punch. Yeah. 2 points that I want to ask about as it relates to the expansion that you mentioned, and you didn't indicate that Secretary Ludlow was going to necessarily go into these. one is, as we have been going forward with the expansion, what can you tell us about our success, lack of success in expanding the number of providers willing to participate in the Medicaid program? And secondly, what can you tell us about wait times, how long it's taking Medicaid eligible folks, people who've qualified, to get in to see a provider?
Secretary Kinsley.
So I will happily turn both of those over to Jay, and to give him just a moment, I will add that what we're seeing in the initial claims is that people are getting care. We've seen over nearly 500,000 prescriptions being filled. Those prescriptions had to be written, and they're getting into the pharmacy to have them filled. We've also seen tens of millions of dollars of dental claims being filled, which is we know a particular area of focus for us, because patients will see a provider. The provider has a certain number of days to bill the managed care program. The managed care program then processes the claim and then passes the paid claim to our team for our data. Because of all this, there's like a 90-ish day lag from when we have visibility into it. We're still not even quite to that lag. As we get into the next few months, we'll have more visibility into exactly what you're looking for. Jay.
Thank you. Jay Ludlam, Deputy Secretary, Medicaid. On the provider issue, I think I spoke about this last JLog, and that was that during the COVID emergency, public health emergency, we added about 750,000 individuals, and by and large, we did not hear feedback from the field that we were having access issues. We have slightly fewer people than we did at the peak, and so we continue to monitor it and monitor network adequacy with the health plans. We do not see yet an issue. As a backstop, while there is a lag to the claims data, we do have what we call our help center, which is specifically designed to help literally one individual, or if they came into us through our member ombudsman hotline, our call center, through the health plans, direct email to me or somebody on my staff, and we immediately work with the health plan or amongst ourselves to get access for that individual. And I can report, by and large, we're not getting a lot of those reports. By and large, it seems like people continue to have access to care. And as the Secretary said, we are seeing prescriptions, we're seeing 31,000 dental claims, we're even seeing healthy opportunity pilot services being provided.
Follow up?
Just one. So I understand that there's this data lag, but it appears that access is there. Do we have separately, or is it also subject to a data lag, sign-ups of providers, and is that list growing or remaining stable?
Jay Ludlam, DHHS. That list, our provider network right now is going through what is called the continuous coverage unwinding for providers. So during the public health emergency, provider re-enrollment was paused. CMS is now requiring us to re-review enrollment from providers. I think on net, we are about even to where we were. We're neither growing nor shrinking, but we continue to monitor it. There is a slide in the deck around primary care providers. We've had a light increase. We saw a decrease. We saw a very good, robust participation. We saw a light decrease, and now we've seen a light rebound from that decrease. And so it's something that we will continue to monitor. I think, too, that having the additional funds from expansion and more people, more adults participating through that model, that we will see more dollars begin to flow and more business opportunity here in North Carolina, that we will continue to attract more providers. North Carolina is a great place to live, so we'll stick there.
Senator Heiss.
Thank you, Mr. Chairman. I guess I'll say that beginning with how how fast the staff works. We'll be sure to take that into consideration when setting dates for new plans into the future coming in. But I guess the question I really wanted to ask really stems from warnings the treasurer was giving us about Wegovy coming in and the potential impact that it would cost the state health plan, $225 million in additional spend next year because of the new drug on the others. And so I really want to ask, are we anticipating seeing the same in the Medicaid expenditure or something similar in the Medicaid expenditures in the cost of the new drug there, or the new drugs there, I guess, the plural, and their cost? I know we talked about syphilis and sickle cell and those kind of things, and that kind of brought up the elephant in the room, I guess.
Thank you, Mr. Chairman, and thank you, Senator, for that question. I will start here. The GLP-1 agonist drugs are phenomenal, and the promise of their therapeutic potential is huge. In addition to the outcomes that we're seeing for individuals with obesity, the FDA just moved to approve them for decreasing risk for cardiovascular disease among individuals that were at high risk for that. They've seen in one study that involved 17,000 individuals that for folks that had had a stroke or who had had a heart attack subsequent to taking the GLP-1 agonist had a 20% reduction in risk for continued situations or continued negative outcomes. All that to say, there's a real value proposition here, and the drugs are stupid expensive. And it's frankly so frustrating to me that they are so incredibly expensive relative to what we see in other countries. And I believe that they're being held back from the people of North Carolina when they could be providing a great deal of value here in the buckle of the barbecue belt. And so my desire is for us to go after this and to figure out a way to both get increased coverage, but to figure out a way that it's got to be cheaper. Our team has looked very closely at this, and I will say right now, the drugs are covered by Medicaid for diabetes. The department does not have an option. We have got to cover all drugs that CMS and the FDA approve, with exclusion of weight loss drugs. There's a federal exclusion that limits us from having to cover weight loss. I would like for us to figure out a way to cover them. I think that we have looked into this, and I can't go into too much detail because there's some issues around the rebates and what rebates the Medicaid program gets versus other things. But I think that we have a way that can still be priced right. And frankly, when we see the investment that it will cost, the value will far outpace, and it will not be the most expensive drug we cover.
Follow up.
Yeah, and I guess because of that, I'll leave it as kind of the aggregate level for what it's eligible to be cost right now. Do you have a sense of additional expense that we should be anticipating versus because its availability was probably unknown at the rebase time that's what coming in. So without changing it or those kind of things, do we have a sense of kind of a cost tied to a drug category?
Yeah, right now, and because it's been covered for diabetes for so long, through utilization management, generally our managed care companies are managing it fine, and we don't see, based off the current approved uses, a particular tick up in costs. The amount of money that we anticipate if we were to open up the threshold for weight loss as well, is in the range of 0 to 10 million in state dollars, which is much cheaper than a lot of the costs of the cardiovascular disease, and from the consideration of the public health investment here, I think a huge opportunity. This ties into the sickle cell paper that we put forward, because we have been proposing to the federal government to cover essentially a significantly larger portion of the match for those therapeutics, so more to 90-10 ratio as opposed to the 66-34. If we could start to get some progress on that front, I think that's the opportunity for all these sorts of drugs that cover these public health areas, whether it's certain HIV drugs, certain sickle cell drugs, etc.
Chairman Bergen.
Thank you, Mr. Chairman. As far as the PHPs and the expansion, talk to me a minute about claims. How are we doing on claims? Because we've put all these additional claims. I would imagine the pharmacy claims are going pretty easy. That should be pretty automatic. What about all the other claims that are coming in? Are we getting everybody paid? Are the PHPs receiving their money on time and everything?
Mr. Chairman, with your permission, I'll turn this to Deputy Secretary Ludlam.
Jay Ludlam, DHHS. Yes, by and large, and I think I have a slide in the deck at the end of, I don't know which one it is.
If you want to wait, excuse me, Mr. Chairman, if you want to wait to handle that.
Yeah, I think the short answer is, by and large, yes, the health plans are paying claims. The volume of individuals, again, going back to the end of the public health emergency, is net. We're about even to where we were, 8 months ago, and so the health plans are able to manage this work.
Follow up.
Going back to talking about the subject that we're talking about so much, and that's syphilis, and the fact that I think we're at number 10 in the nation now, and we just had a child mortality task force and had a discussion about how many children have died. If my numbers are right, about 52% of the babies born in North Carolina are paid for by Medicaid. So is there a plan on how we can get more women tested during pregnancy to stop this from happening? I think it's a huge problem. I know we've talked about it, a number of us have, but have you all developed a plan? I mean, even as going so far as whatever we have to do to get identified and get them tested before they go full term.
Thank you for the question. So to this point, our team has put a number of things in place. First, we've been sounding the alarm to our providers for some time. So for the providers to make sure that women that are pregnant are getting tested and to start that process as soon as possible. As you all know, North Carolina has one of the best laws in the nation with regard to the requirement of testing, that it should happen 3 times. But we need providers to have more awareness to actually do it. And so that is a big gap right now. We have women that are in care that just aren't getting the testing. The second piece is we recently increased payment for providers to be reimbursed more for the administration of the treatment in the office. What a lot of providers have been doing was referring out of office to the local health department after someone had been tested and found positive. And so that way to once again to close the gap so we don't lose women in that process as well. We also know that the therapeutics, the treatment for syphilis, the predominant one has been in short supply, so we've worked to secure a second treatment option as well to bring into North Carolina to expand access further. We've also been working to increase the bundled payment as part of the bundle we pay for birth at the time in the hospital to cover more testing in that moment and more treatment in that moment as well. All of that, of course, as you know well, Senator Bergen, is after the woman, the mother, is known to us. And so, getting people into care earlier is important. That's more of our outreach strategies. We've partnered with HRSA at the federal level. We received one of the first in the nation grants of $4 million to fund a number of FQHCs that are doing outreach programs, doing best practices around education and kind of group prenatal care. We've also supported families with access to doulas. I think there's more that we can do there, so that way people are supported for self-advocacy. That helps, of course, on the maternal mortality side, but also on the syphilis side. So it's going to take a lot of pieces, and we're happy to follow up with you on these pieces. We appreciate your partnership.
Good. We'll take one more question in this segment, then we'll move on into the financial update. We'll call on Representative Cunningham, but I would tell you that Chairman Potts, like on The Voice, he told me he blocked you from speaking. So you may want to cut it to one question. I'm giving you some leeway here.
Thank you, Mr. Chair. I'm glad you're the chair today. I want to go to Paxlovid, Mr. Secretary. The cost Pfizer retail is $1,400. If you have military or CHAMPS, it's $400. If we're covering it under Medicaid, what is your negotiated coverage price? And how much is that if you're looking at a lot of people getting the COVID at the same time and Medicaid has to cover it?
Secretary.
I was really hoping someone was going to sing. I think that we'll have to follow up and get that number to you, and it's kind of akin to the same conversation I was having around GLP-1 agonist. Is the Medicaid program gets a number of rebates at cost, and we have to be careful about how we share that information.
Thank you. We're going to move on into the Medicaid enrollment financial update. Adam Levinson, Chief Financial Officer, Division of Health Benefits, DHHS. Adam.
Thank you, Mr. Chair. Members of the committee, appreciate having the opportunity to speak with you again. Since we last met, well, let's see. Oops, I have to. Luke's still bringing it up. Okay. Don't want to get ahead of myself. Since we last met, the Medicaid team, as the Secretary mentioned, has done an extraordinary amount of work, moving initiatives forward, planning, designing, implementing, communicating, monitoring, and reporting. That said, in terms of the financial metrics, we don't have a whole lot of new information for you today, so I don't want to overpromise. We do have a few pieces of data on slides 3 and 4 that I will walk through, and we'll talk about their implications. But I do want to start off by saying, as I did last time, that the bottom line is that we do believe, based on our current projections, that we will finish the fiscal year within approximately 1% or $50 million of our appropriations budget. So that is unchanged from the last time we met. There we go. All right, so the agenda is the same as last time, but really we're just going to focus on these next two slides and the data that has changed since last time we went through. Just to briefly reorient you, or for anyone who was not here at the last meeting, what this graphic is showing are the enrollment projections for the biennium. The light blue line is the enrollment projection that was a driver of the governor's recommended rebase. The darker line below is the enrollment that funded the General Assembly's rebase, so it's slightly different. You can see that the enrollment projection underlying that funding was lower. And then the green line is the actuals, and it says initial actuals here because it's as of a point in time. If we were to look 6 months from now, that line might look different because in Medicaid, the enrollment is always sort of being updated as we go. But this is a point in time based on the Medicaid monthly enrollment reports. And here we can see that in the 2 months of new data that we have, the curve has shifted up slightly. That's really the most notable thing that we have to talk about today. What does it mean for that curve to shift up slightly? This is the overall enrollment. So an important thing to remember is that each individual who's represented there does not necessarily cost the same to serve. I think we talked last time about how it costs Medicaid a little less than half of the amount to serve a child that it costs to serve an adult. So each individual in this overall count does not cost the same. And when we look at our detailed enrollment reports, what we find is driving this slight shift up in the curve is an increase in the number of children. And so a way to think about that is that the enrollment mix is changing a little bit here and shifting a little bit more towards children. Certainly the line going higher, one would expect that means costs are going to go up because, as we talked about last time, generally our budget is driven by capitation payments, and so an individual means a capitation payment, but again, a capitation payment for a child is less than half of what it is on average for an adult. So the overall curve going up slightly, driven primarily by an increase in child enrollment, is not necessarily costing us much more. All right, and it's hard to see how that might translate exactly into our expenditures just by looking at the monthly expenditure reports. But what we have here is the chart that we discussed last time walked forward for another month of certified actual expenditures from the North Carolina accounting system. And what we see on the right-hand side is that we have now spent, through January, we have spent approximately 53% of our appropriations budget for the year. For comparison, on the left-hand side, the two stacks, you see that we have spent, or that we had spent at this point in the year, approximately 55% of our appropriations budget. So on its face, just by looking at the expenditure reports, one might conclude that we're kind of ahead of pace and trending to be under budget. But what you can't see in here, but you may recall we talked about last time, is that this year's a little bit different. In the first half of the year, we still had a higher federal match, or an enhanced federal match, that was sort of the tail end of the federal public health measures. That was in July through December, and so in those months we were spending for each dollar a little bit less of relatively of state funds. In the back half of the year that we're in now, we're spending relatively more state funds per dollar. So while it looks like we are under budget or under pace in terms of burn rate, we do project that that our spending will catch up, and that by the end of the year, by the end of June, that our expenditures for services will slightly exceed our budget in appropriations for services. But I hate to have to keep qualifying this, but at the end of the day, because of what we believe we will collect in terms of receipts, and in some places where we were able to adjust cost spending downward for some projects, we do believe that we will end the year within 1% of our appropriations budget. I do have to highlight, though, as I did last time, there's still a tremendous amount of uncertainty, and I think what we discussed today in terms of the enrollment trend shifting is a good example of that. There's a little bit of that trend that we might have expected. We know that, as we talked about, we made a policy choice to extend all children, and so part of that enrollment trend is that child disenrollments have gone down. They haven't gone to zero, because there are a number of reasons that some children still disenroll from the program, but they certainly have gone down materially. And so what's compensating in that chart is that there are more new children adding to the rolls than we had projected. And that's just another example of where we don't have a crystal ball. We can't predict precisely what's going to happen. We don't know if that trend is going to continue, or if that is just simply a part of the natural variation. So we're going to be monitoring that very closely. We talked about how last time, and I'll emphasize again, the pace of adult enrollment decline is really the cost driver, again, because the cost of serving an adult is significantly more. So we're going to be watching to see if the trend of more adult redeterminations, potentially leading to more rapid disenrollments, comes to pass. We'll be monitoring our transformation costs, and then there's receipts, of course. And we will be back in the fourth quarter, and we will update you on where we are. Hopefully our projection is good, and again, we feel reasonably comfortable about that range that we've cited a few times. So what else are we looking at? This is just a repeat of what we talked about last time, which is that we are, as the Secretary mentioned, we are working on next year's rebase, adjustments to that rebase based on new data that we do have. We talked about how one thing that's known for sure that's not uncertain is that the federal match is decreasing relative to what we knew when we did the biennial budget, so we have to account for that. And then this is not a rebase item, but in terms of thinking about what you may see in terms of a little e expansion budget, I think I still have to say little e expansion to differentiate, is that while you have funded quite a few provider rate increases, we are aware from the communication that we have with the provider community that there are many provider rates that have not kept pace with inflation for a number of years, some over 10 years. And so in order for us to maintain the access to care that I think you all want for Medicaid members, we'll need to make sure that we can fund the providers at rates that will cover their costs. Mr. Chair, that's all I have. I'd be happy to answer any questions.
Okay, questions? Senator Heiss.
Thank you, Mr. Chairman. When you're seeing this increase in children's enrollment, I know last month you told us that we had put off the determination for children, but we're not expecting that would change anything in enrollment because they all come back on within 3 months anyway, as best I remember that presentation. Seeing this increase in children's enrollment, or fewer children coming off the program than anticipated, are we reconsidering whether there would be no impact of putting off the determinations?
Deputy Secretary. Which one? Adam?
Mr. Chair, if it's all right, I'll start and maybe hand it to Jay. Adam Levinson, NC Medicaid. Senator Heiss, it's a good question. I mean, I think, as I said, this is an example of some of the variation that we, do our best to project, but can't account for completely. The decrease in disenrollments, I think we did expect, and that of course is what we talked about last time, is that we would not be disenrolling children. So I don't think that is necessarily different than what we expected. What we were a little bit surprised by is the number of newly enrolled children, and by that I don't mean the ones necessarily coming back on. That is a group that we have seen that since July somewhat, although it varies each month. I think we were what we saw, and again, I don't know if this is a one-time or two-time or now the monthly thing, but what we saw is more new children coming onto the rolls than we had anticipated.
Follow up.
Yeah, separate area, I just want to get to this. Rates that for Medicaid providers, I get some of them haven't changed since 2012, 2015, some longer than that. But there are some rates in Medicaid that are quite profitable still that may not have changed. Talk to any hospital about orthopedic surgery and they will tell you that they run their entire hospital on orthopedic cost versus everything else in the hospital they lose money on. And so I'm really just kind of get to this concept of, are we anticipating a better review of rates as a whole to bring them in line with the cost of providing a service versus kind of a conversation of, we've not gotten more money since 2012, let's give a, X percentage to that.
Yes, sir. Mr. Chair? Adam Levinson, NC Medicaid. Senator Heiss, I understand what you're talking about. We are probably criticized by some of the folks in the back of the room for maybe not being as aggressive as they might like on moving rates ahead. We are very careful in reviewing the rates and working with industry to make sure we are understanding what's needed and that it's not inappropriately high, I guess is what you're asking about. I think that the rates that I'm talking about that haven't been increased increased. You know, without getting too deep into the information that we have for any one of them, we have received information talking about averages, for instance, in the region, states around us, or other things like that, or demonstrations of costs increasing due to labor costs or materials costs. And since we know that some of those rates have been stuck essentially at a 2012 level, you know, we have evaluated that some of those concerns seem reasonable, in the same way that, you know, if we looked at the cost of labor at just about any other business, if they were paying the same rate as they were in 2012, they'd probably be having a hard time doing business.
Follow up?
Yeah, I think kind of what I'm asking, and I get that for the individual areas, but at what point are we kind of doing this overall evaluation of rates so that the areas and where technology has become involved and those kind of things, and a service can be provided much cheaper now, that we're not continuing to pay at those rates while other providers are facing real struggles, and we don't have the ability to move those kind of rates around? Like, I guess I'm asking this: how do we deal with rates in a more comprehensive approach, other than hearing from the ones who are struggling to make it?
Adam.
Mr. Chair, yes, Senator Heiss, Adam Levinson, NC Medicaid. Senator Heiss, I think I understand what you're asking, and I think we share that desire to have kind of a comprehensive review. In some of the cases, I will say that you know, some of the reviewing that we do is potentially part of a rebasing, and some of that is based on cost reports. Sometimes, you know, and not always. Across the different provider types, there's just quite a range, and so there's not always cost reports, for instance, and so we are having to use a little more judgment, do a little bit more research. We don't necessarily have a rebasing process in place for all provider types, but I think we have talked at Medicaid. I don't want to get too ahead of us, or what the Secretary might say, but I know that we have talked about getting to a more standard way of evaluating rates and working with you all to evaluate rates, potentially doing something like they've done in the last year or two in Indiana, where they established a schedule by which certain cohorts of rates would be reviewed by the legislature, every couple of years, and that in between that, there would be an automatic, just kind of cost of living type inflation increase to make sure that nothing languished. So I think we're open to what I think I'm hearing from you, which is a little bit more standardized way to make sure that we focus on all the rates and that we try to right-size them, and that it's not just a question of maybe who is you know, providing certain information or yelling loudest.
No other questions. We're going to move into the transformation update. Ask Jay Ludlam to give us an update on that. Thank you, Adam.
All right. Good afternoon, everyone. Again, my name is Jay Ludlam, Deputy Secretary for Medicaid. It's a real pleasure to be here this afternoon. While Luke pulls up the presentation, I do want to start with something a little. We're going to do a security update. I do want to go a little off script and provide an update on something that many of our providers and you all may have heard about. Our providers are tracking really closely, and that is the cyber attack of Change Healthcare. I think it was about 2 weeks ago now. We maybe even headed into week 3. So if you bear with me for a second, I'm just going to read a little bit of what we are doing and give you a light overview of what happened. But there was a cybersecurity incident at Change Healthcare, and some of our providers, managed care partners and providers were affected. And while they disconnected their systems and what have you, it is something that we have seen morph from a cyber attack technology issue to becoming now one about provider payment and cash flow. So the first community affected probably was the pharmacy community. We do point of sale services. And so that means that there were pharmacists who were literally submitting the claim in the moment with the customer in front of them, and then they had this error or this, whatever the attack, whatever it looked like for them. We have protocols, though, for our pharmacists, and, they were able to continue to fill prescriptions in good faith and provide emergency supplies to our members. Many of the pharmacies have switched clearinghouses, which is what Change Health is. It's a clearinghouse. And so we have seen stability again largely seen stability in our pharmacy community. We continue to monitor our call centers. I think we anticipated a big hit from providers and members, and we are not seeing that now. We have worked with our managed care partners. Our managed care partners have offered hardship payments to providers. They have waived timely filing for 60 days, starting on February 21st, and may continue to do that if necessary. They are also working with providers on, some of the technology issues. Some of our independents struggle with switching clearinghouses. It sounds easy. Well, it doesn't, but it's not. And so many of our managed care partners are supporting providers. So by and large, unlike some other states, we are starting to see some quiet, but that doesn't mean that the issue isn't over. And we stand ready as a division to support providers if they need hardship payments as well. And just wanted to provide that update before I began. All right, so tailored plan readiness. We continue to work very closely with our tailored plan partners over the last couple of months and leading through consolidation. Many ways consolidation was a component of readiness. And so we have been working very closely with our four tailored plan LME MCOs over the last couple of months to validate readiness. It is absolutely kicked into high gear over the last couple of weeks, especially since the beginning of the new year. And March will be a very busy time for the division and for the health plans. We're reviewing contract deliverables, network adequacy, and the functionality and system readiness. A couple of highlights, 1,287 deliverables have been reviewed. We have 28 sessions with the health plans over the next week just to go through some of their policies, validating that their call center representatives understand and can answer North Carolina specific questions and be able to support members and providers not only through the transition but also afterwards. We've talked a little bit about the network adequacy generally and related to network adequacy for the tailored plans in particular. We've talked about primary care disruption, and we continue to monitor that very closely. The health plans are making very good progress, and we continue to monitor any outstanding issues. So that is going well. And then on the technology operations testing, it is almost a badge of honor when we have the tailored plan leadership or any leadership at these health plans complain about how much testing we do, that they don't do that much testing in other markets. Why do we do so much testing? And it's really important for us not only to validate the systems, but it also flushes out any weaknesses that we could go live with it, but we need to develop a mitigation or validate a contingency with the plans or with ourselves. Sometimes the issue is going to be on the division. And so we do user acceptance testing, we do system integration testing, and we do end-to-end testing. And since I talked about EVV last time, I'm not going to go into the technology issues related to each of those 3 testing paths, but it is fairly comprehensive that we do with them. This is the timeline. There is no change from what I showed last session. Like the timeline says, we are in between on-site readiness and visits and all that end-to-end testing and getting ready to start sending packages and enroll individuals in tailored plans. The Secretary mentioned this as well, and we appreciate the opportunity to launch a statewide health plan focused on foster care and families, children. This is a very exciting initiative, the way North Carolina is approaching it. We talked briefly about a policy paper that we put out, and we are continuing to review feedback, and we will make changes to the contract as necessary. We have a couple of points between now and when it's awarded that we can do that. The RFP itself was released earlier this month, and for various reasons, I can't speak about it. We're in what is called the silent period. Don't want to advantage or disadvantage any potential new partner. And responses are due, and evaluation will begin in May. And so we've already begun that planning, and we are in the process of taking that contract and breaking it up into activities so that we can formulate the readiness plan for the new CFSP. Last time we talked a little bit about electronic visit and verification. What I will say is that we have directed, actually, before I say that, this is an issue that we only had in standard plans for health home. This is something that is working in standard plans, personal care services. It's something that's working in NC Medicaid Direct. That's the fee-for-service program that we run right here. And it is working in those scenarios. It is not working. Health home EVV is not working in standard plans. So we did require the health plans to reverse changes in their systems. It's called hard launch. They are now back into a soft launch, which is providers can submit claims. They look at the systems, look at the claims. They provide recommendations for errors, but the provider is paid for the service. When we go to hard launch, we will get denials or approvals, but that is not where we're at. The health plans are in the process right now of going back through claims that were submitted between October and mid-February, and they are in the process of reprocessing them. We are getting reports on their progress, and I encourage the health plans to move swiftly to get providers paid for those services. The last part is that we did ask for plans from the health plans on how they will get into compliance. They've submitted those plans. We are reviewing those plans. We're trying to find common efforts and ways that we can support them in the work and make sure that we are holding them accountable for that delivery. I do think, too, that part of what we'll need to do this time is make sure that providers remain engaged, that they go through the training, and that we see their ability to actually do their part. And so we'll be wrapping support for them as well at this time. Of course, we'll work with industry at the right time to share the plan and the approach. We've already met with them a couple of times, as well as the health plans. We did a big kumbaya, we brought everybody together. And so I think we're going to make good progress on EVV. The last is a topic that we talk about a lot, and that's around claim payment. We talked about claim payment last time, just to keep it fresh, tried to bring a different view. So here we have average processing time for claims, and then average processing time for pharmacy claims. So I think one thing to look at on the top, or actually in either scenario, it takes longer to deny a claim than it does to pay a claim, in part because you often will ask for more information or contemplate or validate that the denial is correct. And so you do see a slightly longer time frame for some, and so that's something to watch. But by and large, providers are getting paid, in under 20 days after submission, but we continue to monitor this. We have a website with a dashboard that you can click around on and look at different views. I think it starts in a claim count view, and then it moves. If you click a button, you can move it to a dollar view, so you can see where the dollars are going and who's getting denied and who's getting paid. So that's it for that presentation. I don't know if we want to do questions now or come back to it at the end.
Yeah, let's just go right into the next one, then we'll do a combination of questions.
All right, fantastic. So this next presentation will be on NC HealthWorks. We have a code name internal to Medicaid. We call this Medicaid expansion. So that's our secret project name for this. But we will providing an update on NC HealthWorks. Secretary's already said it. We had to put a plus. We knew we'd be a little higher when we created this deck, but we have 389,411. I looked it up. I knew it would come up today. We've been averaging about 1,000 people a day. I think that at some point this will plateau, and we'll then just be on either a run rate or a slight decline of this. But it's been a topic that we've talked about, and we continue to monitor it. And we'll talk a little bit in a second about how we're supporting counties. Again, we're entering the phase now where we really will rely on media campaigns and our community partners, which have been critical to our success in getting to go live, getting their counsel on how to approach various communities across North Carolina, both geographic and demographic, and really a model I hope to be able to replicate in other areas as we roll out new programs. What we're doing is we're bringing community partners in-house. We're working with them on policies. They're advising us, telling us what we're going to do well and what we're not going to do well for their community. And then we also provide them with tools, communication tools that they can use and tailor for their particular community that they're trying to influence. And then we also have data. There's public dashboards, which are at the back of this deck, that they also use to understand whether or not their particular campaigns have been successful in accomplishing their goals. I do have a correction on this slide, and it is the word application on the last bullet. It really should read redetermination. And so the application processing is different. New applications are for new people. Redetermination is for existing. We are doing 41% redetermination. Our application levels are not that robust, but it is just a more complicated process to allow somebody in rather than to redetermine them continuing to be eligible. So apologies to the committee for that mistake. We'll try to provide a correction. I've been asked to provide an update on what we're doing with the signing bonus. So just to remind the committee, one of the benefits of Medicaid expansion, in addition to the opportunity to cover 600,000 more individuals on Medicaid for full coverage, was $1.8 billion that will come to us in tranches. And so what I'll share with you is what we're doing with the first tranche. Is that the right word? Is that a finance word? All right, thank you. All right, so I think Representative Potts would not want me to read every line on this. And the next slide, is that correct? All right, excellent. So I will, and if there's more detail needed by the committee or members, happy to provide that. But next slide, $158 million in allocations to these organizations and entities. And then another tranche of about 40 million, a little over 40 million, going to other entities, universities. Sorry, yes, yes. All right. Here, I'd like to thank the committee for the opportunity to connect to the federally facilitated marketplace. It is relatively new for us, and we continue to get more data in, and hopefully in the next presentation or in a future conversation be able to share with you some of the impact of the FFM. We call it the FFMD because it's for determination. It is very helpful for our county partners. What it does is it allows for people to apply, and the liability of an inappropriate enrollment falls on the federal government rather than on our county partners. It also, the information is able to be ingested by our computer systems. So there's little human activity that needs to take place for applications on the FFMD. And so that's really helpful for our partners. Our focus has been on automation. We've talked a lot about the struggles that our county partners have related to hiring, maintaining. Medicaid is not an easy program. There is a lot of pressure on counties to get that right, which is fair. But it means that we need solutions other than throwing more people at the problem. And so we have made a lot of effort to work on automation, computer system, and data matching. And I think we've been largely successful, though we will continue to focus on that. And so you'll hear automation is also straight through processing. That's another term that we use for that. We have talked also already about some of the policy flexibilities. Really, again, our focus, based on what Adam had said a little earlier, our focus will be on adults. Making sure that adults are in the right program, whether it's in Medicaid, Medicaid expansion, a limited benefit, or not on the program at all. Our focus is compliance. It is making sure that the people who qualify and are entitled to the benefit have access to the benefit, and those that don't are not on the program. And by using our policy flexibilities to free up our county partners to focus on those adults is really key. Representative Blackwell asked a little earlier about enrollment in Medicaid by providers. This is the same slide. I'm happy to provide greater detail for various provider types if there's another provider type other than primary care. I do want to thank again the General Assembly for the opportunity to do the primary care provider task force, which is an opportunity for us to define across the entire state, not just in Medicaid, what is a primary care provider, where do they practice, from a data perspective, how do you identify them through taxonomy codes, what place of service can they provide, in addition to some other components that go with it. Just measuring it isn't necessarily the end of this project, but the task force has just wrapped up its last meeting, and we will begin finalizing a report that we will submit to the General Assembly in the next couple of weeks. And this last slide I will not take. It's just a number of resources and data tools that are available to you and to anyone to access. This is part of our effort to be transparent on how our health plans are doing with claim payment, how we are doing on the continuous coverage unwinding and enrollment, in addition to the impact of expansion. That's it, Chairman.
Thank you very much. Chairman Potts has a question.
Thank you, Mr. Chair. I was looking at your claims update information on page 6 of the previous presentation. It appears 1 in 4 of every claims are denied by one company and 1 in 3 by 2 others. 2 of them seem to be processed, and I realize there may be some acclimation time involved in this, and these numbers are a few months old, but when 34% of your claims are denied, either you've got a problem with those processing the claims or with those sending the information in. Could you elaborate on that? Thank you.
Yeah, thank you. Jade Ludlam, DHHS, North Carolina Medicaid. The issue of claim denial, I think we've been talking about it for a little while now, and I think that there are scenarios when there are legitimate claim denials. I think though that what I'm particularly focused on is not only the claim denials, but it's the administrative burden that comes with the claim denials, and that is something that we are working with our health plan partners on, and looking for additional ways to provide them with certain flexibilities, but at the same time hold them accountable for just the results of inappropriate denials. And I think that that's really the core, is that administrative burden from inappropriate denials. And that is something that we talk about a lot with them. We talk about that a lot with providers. I don't know that it's necessarily a capital C concern, but it's definitely a problem for those providers that are getting denials, that when they push back, they get reversed and paid. And I'm not encouraging my health plans the health plans to deny and stay denied. But I think it's the administrative burden that is really the issue that I'm most concerned about.
Chairman Bergen, good follow-up.
I'm still not understanding why they're denied so many claims. I understand you explained the process and the burden of it. What is the leading cause of this, if there is one?
The leading cause of denials, I don't actually, one of the and I don't have it in front of me, and is claim denial reason. So we actually have a report that I'm very happy to share with you, sir, that shows what are the top denial reasons for the health plans, and that will give you a lot of insight into what those issues are.
Chairman Bergen.
Thank you, Mr. Chairman. And thank you for asking that question, because at one time, it was a lot of pending claims. Instead of denying, the plans were just putting them in the pending category. And in digging down, we found that there were a lot of claims that were not being paid for children, especially newborns, and the way they were handling is that continuing to be a problem? And do we need to look at a different method where we put a time on a claim that walk through this with me? Like right now, you've got 30 days on there. Are there a lot of claims going much longer than 30 days? Do we need to look at our PHP friends and say, look, at the end of so many days, you go ahead and pay, and then we'll keep discussing this? Because we've got providers that are owed and were owed millions of dollars that, I think eventually a lot of them got the money, but can you just kind of walk us through the pending, the denied, and then how much money we're really talking about in the denials?
Jay? Yeah, thank you. Jay Ludlam, DHHS. The issue you're describing, and we're not good at marketing at Medicaid, so we called it the newborn issue. And what we identified were pended claims for a specific kind of claim. We have worked with the health plans on that, and I think that we have by and large eliminated that as an issue. And there was hundreds of thousands of dollars, if not millions of dollars, to individual or across the hospital systems. It also, oversight is something that you continue to mature and grow as you get more sophisticated, and now we have pending claim reports. And so while we try to reduce the number of reports that we ask from our health plan partners, we had a new one now, a pending claim report, in order to get at those kinds of issues. I think that a couple of good things that came from that is that I am aware that the associations are speaking more frequently now. This is something that hospitals and health plans can work out on their own. The department stands ready to support either or both if they reach an impasse. But I think that now the systems and the health plans are speaking more frequently and are able to resolve issues more quickly. But the newborn issue, I think, is I haven't been tracking that in a long time. So I think that one's over. And Chair, if you could indulge me, I think I have a better answer for Representative Potts. It's great to have the A team of my Chief Actuary, Julia Lurch, my Deputy Medicaid Director, Melanie Bush, with me. So they've helped me better read my chart. And so the claim status, the 34%, sir, and I don't know if this is how you read it, that's actually 34 days. 34 days. So it takes 34 days to deny the claim. It's not that 34% are denied. It's that the claim on average is denied after the 34th day. Not to reopen a closed question, but and we can, again, I'm happy to meet with you, Representative Potts, afterwards.
Well, I would add, I do think it's worth drilling down into the weeds a little bit.
Okay.
Are there frequent providers where there's a higher percentage of denials at those locations?
Yep.
Is it real clear what the expectations are? Those kind of things that we probably ought to do a little bit more digging.
Absolutely. Happy to share that. Yes.
Okay, very good. We'll follow up on that a little bit. Representative Cunningham.
Thank you, Mr. Chair. I'm on that slide 6, the claims update. And one of the things, I understand the clarity on the days, but one of the things I wanted to understand is if those claims are extended out to a certain amount of time beyond, like if we got Blue Cross Blue Shield, and they say if that claim is not in my office and submitted by 6 months, then we're not going to take it. We're not going to deal with it. Or it reverts back to someone else taking the loss on the cost of the service. What do we have in place if a provider has provided the service and they're continually going, not receiving their payments beyond 30 days, even possibly to 6 months? What options are on the table for them? The last question is everybody using the same system that are providers under the LMEs and the MCAs? Is everybody being cohesive in what they're doing so that you don't have so many technical issues once the providers come into the system? Thank you, Mr. Chair.
Jay Ludlam, DHHS. Thank you for the question, Representative Cunningham. So what the first issue you described is, I think it's called timely filing. So originally in the Medicaid managed care program, we had a 6-month timely filing period. That meant providers had 6 months after the date of service to build a health plan. What we found was that many providers needed more time. So last summer on July 1st, we extended timely filing to 1 year. So we extended that. Related to what options providers have, of course, they should be reaching out to there's a contractual relationship between the health plan and providers in most cases. They should absolutely look at their contract and work through their contract and make sure that they're following the steps there. There's also a provider manual and a provider representatives or relations managers that the individuals should reach out to for satisfaction. Knowing that doesn't work all the time, they can always reach out to us. And in the past, I feel like for the first 18 months, I was presenting our help center tickets and our progress on help center tickets. And that's what the help center is for. The help center and our provider ombudsman program is here to assist providers in clarifying policies and helping them find the right contacts at the health plans if they can't, and then trying to work with the health plans to get those claims corrected and reprocessed. So that's something that we do. And then your third question about systems, that's a little bit more complicated. We do have now 9 health plans here in North Carolina. And admittedly, all of those systems across the health plans they've got some similarities, but they're different. And that means that our providers have to know about those 9 different systems and be able to manage them. We work with our health plan partners to simplify and standardize business processes as much as possible across the health plans. And so that's something, but it is admittedly a challenge to have 9 health plans and those 9 different systems.
Helpful. Senator Heiss.
Thank you, Mr. Chairman. As we're going through the PHPs making payments to providers, what are we learning about our MMIS system that we made providers prior? I'm hearing of other cases where providers are upset they're not getting paid for something, but it might have turned out they never should have been getting paid for that. Our system was just automatically approving it, and these kind of newer, more updated systems are doing what they should under the logic of Medicaid, and that's different than what we found. So any kind of concept of where we may have been making overpayments or other things through the...
Yeah. Thank you, Jay Ludlam, DHHS. When we get a help center ticket or we get a report from a provider or an association of a problem, a lot of times they want quick satisfaction. They want very fast, just turn around. It's clear what the problem is. Because of when we started and our move to Medicaid managed care, we actually take our time, and part of what we do is we review our policies. We start there. Rather than assume that we got it right, we actually challenge ourselves and go back through our policies. Sometimes we'll go back to CMS and ask them clarifying questions. We will go through our system, which is written in COBOL and does not have very clear business rules. So that's a challenge. We have to pull those rules out. And we then look at the contract regulations that may have come out, there's a lot of analysis that goes into evaluating whether or not the denial is accurate or not, or the payment is accurate or not. And through that process, oftentimes, well, I shouldn't say oftentimes, that was actually a complete mistake. From time to time, we will find that we may have communicated the wrong policy to the plans, or we may have programmed the policy incorrectly in the system, or it was correct in the system, but we haven't updated it. And when we do that, it's an opportunity for us to not only reflect on what we could have done better to catch that, but also an opportunity for us to update our system, our policies, and our contract with the PHPs. And this is in part why it can be frustratingly slow for some providers to try to get some of these provider payment issues resolved. But that's our approach. I think that in a couple of, I'll say it, years, I think as the program is more stable, and we've gone through all the policies and reviewed them at one point very deliberately in this context, we will be like other states, and we won't reflect on how it's currently programmed, and we'll just look at kind of our systems and we'll go from there. But it's through that process, sir, that from time to time we do find errors.
Well, along those lines, I guess kind of what we've done in the past, but not everyone is on managed care at this point. Have we improved our payment system and our DMMIS operations as a result of what the PHPs are doing with their clients?
Yes. Yeah, thank you. Jay Ludlam, DHHS. I'm trying to think of different ways to answer your question, but absolutely, we are committed to improving our compliance, improving the quality of our member experience. We're very focused on supporting our providers and the work that they do. Without our providers, it's very difficult to run a Medicaid program. So absolutely, we are reviewing our technology. We are reviewing our policies. Like I said, we don't presume that we're necessarily right, but we do have an incredibly talented staff, small and mighty, but talented staff that understand where to go, where to look, how to poke, how to push, and in the end, we're striving for the best answer in the time frame and in the budget that we have. But we continue to make investments in our systems, right-sizing it against the fact that we've moved to Medicaid managed care, and that's really where we should be putting a lot of our time and energy. But we're not ignoring our systems.
Representative Blackwell, and you'll be glad to know that Representative Potts already used his one block, so you're free to speak as often and as long as you'd like.
I think this is going to be brief, and it maybe is a little...
Could you call the Sergeant at Arms, please?
A little bit of a follow-up, perhaps, to Senator Hayes' last question. I think he was asking if the department was learning things in the process that it was able to incorporate, I guess, to do things more efficiently or better. You mentioned the issue in dealing with providers that they might have to deal with 9 different plans, and there would be differences among those plans in terms of what they have to do. But I'm wondering, is it the case, or is it too early to say, that although they may have to learn those things, that the fact that we are allowing 9 different plans with their differences, that also generates differences that we can then choose upon, and maybe somebody else can improve their way of doing things because they observe or hear about the other. In other words, sort of the theory that competition sometimes and the variety maybe can be beneficial, and I'm wondering if you observe any of that at this point.
Yeah, thank you. Jay Ludlam, DHHS. Thank you for that point, Representative. one of the foundational principles that we strove to build into kind of the core or the philosophy of Medicaid managed care here in North Carolina was the desire for market competition and innovation to drive value. And I think that the key is whether or not the differences are different for the sake of different, or if they're different for the sake of value. But I do think that when we see best practices, we encourage the plans to come together and understand those best practices. We see too, if some of the plans are underperforming, or maybe if they have high denial rates, some providers may choose not to contract with them. So I think we see it on both sides. I don't have a good example, mostly because I'm on the hot seat right now. But absolutely, I'm confident that the health plan partners are writing down about 5 things that each of them do that separate them from their partners, but that they've shared because it's a best practice and it's in the best interest of members and providers here in North Carolina.
Follow up?
Finally, just a comment that I wanted to ask that question. I like the answer, and I was hoping maybe you would say something along that line. But, I would hate for our providers to miss the point that the innovation that is allowed by having this competition may ultimately be more to their benefit than the convenience of having a standardized form and you're stuck with it and there's no opportunity to try something different, because we're interested in standardizing as opposed to offering that opportunity to innovate.
Thank you. Okay, well, let's move to the last item. We got Direct Care Workforce, Kelly Crosbie.
Hello, everyone. Kelly Crosbie, and I'm the Director of the Division of Mental Health, Developmental Disabilities, and Substance Use Services. And I'm here today to talk about direct care workers, a topic that's near and dear to my heart, but it probably is for most of us. Most of us have direct care workers in our lives, whether you think about it or not. So direct care workers take care of our smallest children. They take care of our parents and grandparents as they become older adults, and they take care of individuals with disabilities or people who have even short-term injuries. So most of us have direct care workers in our lives at one point or another, so they're incredibly important people. I'm going to talk about a specific subset today. Jay, could I have the clicker? I'm going to talk about, clicker is the official term for this. I hope I hit the right. Is it the big one? Did it go? Okay, good. I'm actually going to talk about a subset, our direct support professionals. So I'm talking specifically about people that provide care and support to individuals with intellectual and developmental disabilities. And I hope we all know what that is now. So folks with intellectual and developmental disabilities are folks with Down syndrome, cerebral palsy, Fragile X, fetal alcohol syndrome disorders. So direct support professionals provide an array of services to help people with intellectual and developmental disabilities live independently in their communities. And that is everything from bathing and dressing and feeding to helping people go out in the community and shop, go to church, go hang out with their friends. They help them get jobs and coach to learn their jobs and maintain their jobs. And direct support professionals also really help families. So because individuals have direct support professionals in their lives, families are able to have their own jobs. They're able to integrate in their community as well. So there's a far-reaching impact of direct support professionals. So let's look at our workforce a little bit. Not surprisingly, but unfortunately, we have a very high turnover rate in direct support professionals. It's about a third. So it's about 33%. And most people stay in their jobs less than 3 years. So that's a real problem. About 90% of direct care workers are either women or people of color. Turnover really hurts. It hurts consumers who need consistency, who rely on direct support workers to, again, take them to their jobs, take them to their activities, take them to church. It hurts families. They're not able to go to their jobs because they need to take care of their loved one. It hurts providers because it's very expensive to recruit, retain, and train new staff. Now, here's some good news. You all know this, and we're very grateful to you for it. We have an expanded opportunity to provide more services to people with intellectual and developmental disabilities. So we have more waiver slots. Thank you for that. And we're always going to keep asking, so thank you for the more waiver slots. We have the 19 to 15I option. I know that's very jargony, but it literally is waiver services for people on the wait list to get an innovation slot. These are amazing. So people can get those same services that I talked about. The name for that service that I talked about, where they help a person get ready for the day, go in the community, enjoy themselves, that's called community living supports. So that's the biggest service that is provided by direct support professionals. But they also provide supported employment, again, so people can get jobs in the community. They provide respite, which is a big deal to families. So families can get a break for a weekend or a week sometimes. So these benefits are incredibly important. But we do have a workforce issue. So we've created the demand, we've created a wonderful benefit opportunity for people, which is really exciting. But in order to meet the needs of the over 17,000 people on the wait list, we're gonna need about 20,000 more direct support professionals. So that's about 1.3 workers per person. So that's a lot. It's a lot of workforce, but it's also a lot of opportunity. So this is where I thank you all, and I mean it. I'm really grateful for the dollars, for the champions here on this committee, for the champions in the IDD caucus, for the champions that are in the crowd behind me. We got some really significant funding to help with direct support professional rate increases, so money going to workers, to agencies that hire, recruit, retain workers, to families that recruit, retain, and hire workers. More money for personal care services. So a lot of people on the wait list are getting personal care while they're waiting for a waiver slot. So that's actually a really important service. Again, it's really important for members, but it's important for families too, especially some of our older folks. Personal care can really help with their adult children. You also gave us about $18 million for behavioral health workforce supports, and we're using that in a variety of ways. In a couple of weeks, I think we're going to do an update on behavioral health spending, that wonderful package that Representative Lambeth championed. Some of that money is for workforce, and we're going to use a portion of that for direct support professionals. So hold that thought, I'll tell you more about what that means. So we do have challenges. I mentioned turnover, and turnover's bad, and we have services, but we need more workers. The reality is, and this won't surprise you, right? Rate increases aren't keeping up with the cost of living. So workers are able to find, in some cases, easier jobs, quite frankly, that pay better. So sometimes it's easier to work at the Amazon warehouse, or to go work at McDonald's or Walmart. Sometimes you can make a better salary, and that could be more attractive to people. We have this wonderful legislation, but it didn't necessarily require a particular rate floor. I will say we feel very united, right? We're united with you. We're united at the department. We're united with LME MCOs, providers. That money is for workers, right? Because we need workers. We need stability in the workforce. We need people to get services. Training is a bit inconsistent across the state, and it's really hard, right? So we hear a lot in particular from families. When you think about direct care, it's very personal, right? A family or an individual really picks the worker that meets their needs and fits with them. And this is someone who's intimately involved in your life. And so it's important you get the right fit. But we hear a lot from people that, they've got to train and retrain those folks. They're getting basic training, but depending on where they come from or their years of service in the field, training can be really inconsistent, and that can take a lot of time and energy. A big issue is that we don't actually have a pipeline to create new direct support professionals. So I always tell this story because it was so startling to me. I had an intern. The governor has a PAGE program, and an intern came to work with me for a week. And she wanted to be a CNA because she wanted to work with older adults. And I said, oh, have you ever thought being a direct support professional? And you can work with folks with intellectual developmental disabilities. She'd never even heard of that as a career option before. Most people don't. It's not really a career option. You hear about in high school, there aren't internships for it. We don't have a community college program for it. We don't have apprenticeship programs. Hold that thought though, right? We're working on it. But that idea that this is a career, it's a career, it has a trajectory, you can work your way up through the career, it's meaningful, it might be a career you always want. We don't really have that right now, and it's not something we're marketing to young people, so we need to create that pipeline in a career path. And currently there's very little opportunity for advancement. So pretty much when you enter the field, you continue to do the same services. If you have 1 year of experience, if you have 10 years of experience, there's not a lot of room for career advancement. There aren't stages like a lot of us have the privilege of having when we go through our careers. But we have a plan. So if I'm sure the secretary has mentioned the caregiving, the strategic caregiving workforce committee that he convened with the Department of Commerce. So out of that came very specific suggestions suggestions for nursing workforce, behavioral health workforce, and direct care workforce. So we have taken those recommendations as well as additional recommendations, and we're putting together a comprehensive direct support professional approach. We have an advisory committee right now. We host an advisory committee, and it really is a partnerships because this takes everyone. So we've got consumers, direct support professionals, families, providers, LME, MCOs, community colleges, counties. So we have an advisory board, and we've been putting forth some ideas for a more comprehensive direct support professional approach. So we're looking at everything from a career path. So we need a recruitment campaign starting way back in high school. We want to have standardized training so people feel confident that they got training, and there are levels of training too, so people can work up. They can get more training. They can move up career-wise. They can get paid a better wage as they move up the pathway. We're going to continue to advocate for living wage increases. What industry wouldn't? So of course we want to make sure that folks are getting cost of living increases. And we are working with providers and LMEs on incentives and employment and supports. So again, for providers, it's really expensive to recruit, retain folks. For a lot of people in this career, it's hard. It's a part-time job, or it's putting together a couple part-time jobs. So you don't always have benefits, and you're like everyone else. You need money if you're going to go back to school or for childcare, or maybe even an incentive bonus if you stay with a consumer or a family for 6 months or 9 months or a year. So we're looking at a comprehensive recruitment, training, and compensation strategy for direct support professionals. We're very committed. The last thing I want to leave you with is we're very committed to helping individuals with intellectual and developmental disabilities get service. You've given the opportunity for us to have services for them. This is a wonderful thing. So now we need to work on the workforce. We need to develop, recruit, retain a high quality workforce so people can get those life-changing services. Thank you.
Very good, thank you. Let's see if there's any questions. We're over a little bit, but let's see if there's any questions. There'll be a whole lot more information as we get into the future. Senator Heiss.
So, and I'll make this one quick. When you put one of the challenges was that the rate increases may not have gone. Do you have anything like what providers did not raise wages when they received a higher reimbursement rate? I know from we heard from the whole industry, 100%, that's exactly what they were going to do with it. And if that's not occurred, we need to know that.
Yes, thank you, Senator Heiss. Kelly Crosbie, Director of DMH DDS-US. I'll start and maybe I'll hand it over to Adam. So again, the Medicaid team, in partnership with our team, did a lot to work with LME, MCOs in the community on the intent of the legislation. So it was very clear in webinars and in the Medicaid bulletin that the rate meant it really should go to workers in increasing rates. And Medicaid has developed an attestation process, so employers can say how they intend to either raise wages or give benefits or things that directly impact the workforce. But Adam, can I turn it over to you for anything you add about watching that?
Yes, thank you. Adam Levinson, DHHS, NC Medicaid. Yes, to follow on that, we've worked very hard to make sure that the legislation has been translated into the information on our website, and as Kelly said, we've had a number of webinars, which are essentially big phone calls where we've addressed questions. We have fact sheets that come from that, so we're trying to make sure there's clarity about requirements, and then also, but within that, the flexibility that providers have, because it is, as Kelly mentioned, there's not a specific amount in the legislation or percentage that's required to be passed on, but you were very clear in the legislation that it was the intent of the General Assembly, for these funds to be used to the benefit of the direct care worker. And so, there's a little bit of that tension there because there is flexibility in what the providers can do with the funds, but we've set up the structure. You all directed us in the legislation to establish standards for reporting. That reporting will be done to the LME MCOs who are really administering this, but we set up, as Kelly said, that the front end, I would say, the attestation that says, the provider says before getting the funds, we will use them to the benefit of the worker, and as that's illustrated in the materials. And then on the back end, there is a way for LME MCOs to have each provider document what they did with the funds at the end of the fiscal year. different. So there'll be some monitoring of whether the funds were used consistent with the legislation. But we are very aware that that can mean a lot of different things. There's no specific ratio, there's no specific amount. So as long as it's justified that it has been used to the benefit of the workers, they will be in compliance.
Representative Cunningham.
Thank you, Mr. Chair. I'm going to be brief and just make a few comments. First of all, if the people on this committee see you all like I see you all, you actually over there running a machine, and it has a lot of moving parts, and it's very complex. And I don't rub egos. I don't do that. But I'm sorry that the secretary is not here to hear me say it. You all are doing so much over there that even coming to committee and hearing what you're doing can be overwhelming. And I want to thank you openly because you are doing a lot and we're watching. And so I thank you for what you do.
Thank you, Representative Cunningham, for that comment. Other comments? If not, I do want to acknowledge the Sergeant at Arms, the House, Ray Cook, Russell Salisbury, Glenn Wall, David Lighton, and then the Senate, Tequila Cogdale, Rod Fuller, Dean Gustafson, Sherry Hedrick. We thank them for their work. You know, as Chairman Potts called out, we needed help there one time to control the rowdy representative from the Charlotte area. But otherwise, we had a really good meeting. We thank you again for your work. We look forward to seeing you here in April. So have a great, as the weather's getting better and daylight savings time's back, enjoy this outside fresh air of North Carolina. Thank you, and we're adjourned.